I will be discussing a very specific issue, capillary microvascular dysfunction as a predictor of immediate cardiovascular outcome in acute coronary syndrome. The coronary microvascular circulation consists of the prearterioles, the arterioles, and the capillaries, and they account for 95% of the total resistance. The epicardial vessels are just conduit vessels responsible for only 5% of the total resistance. And when you look at the role of coronary microvascular dysfunction across the different cardiovascular disease, there are a lot of situations: angina, Minoca, Takotsubo syndrome, acute coronary syndrome, obstructive CAD, and even heart failure with preserved ejection fraction, and the various cardiomyopathies. The coronary slow flow phenomenon is characterized by angiographically normal or near normal coronary arteries with a delayed opacification of the distal vasculature. Far from being a simply angiographic finding, it has clinical implications such as angina, acute coronary syndrome, and sudden cardiac death. What is the prevalence of coronary slow flow? It varies between 1.5% to 7% and is very common in the young male smokers. And that is what we find in our day-to-day practice when you do a coronary angiogram in a young male smoker. Apparently normal epicardial coronaries. And these are all the proposed mechanisms: the structural, the physiological, the molecular, among which the microvascular vasomotor dysfunction, the endothelial dysfunction, and the increased resting coronary microvascular resistance are important etiological factors. And stress cardiomyopathy, the important issue is the catecholamine release. In relation to the physical stressor or the emotional stressor in someone who has an intrinsic susceptibility. The three important factors will be multivessel epicardial spasm, microvascular dysfunction, and myocardial stunning and minor injury. The important pathophysiological mechanism: microembolization, the obstructive emboli, the platelet neutrophil aggregate. It can be a spontaneous embolization or happening during the procedure. And the microvascular structure, the loss of viable cell-cell junction, the leaky capillary, the endothelial inflammation, and the endothelial swelling. And these are the three important things: the ischemia, the reperfusion, and the atheroembolism, ultimately leading to endothelial damage, tissue edema, the platelet and fibrin embolization, the release of the oxygen-free radical, and ultimately culminating in the no reflow. This is the initial article, Michael Gibson, published in 2000 circulation, 762 patient, the TIMI 10B trial, tenecteplase versus TPA. And the myocardial perfusion grade, we know that. The grade 3, normal ground glass appearance of the blush. Grade 2 will be dye strongly persistent at the end of washout, gone by the next injection. Grade 1, the stain is present and the blush persists on the next injection. And grade 0 will be no or minimal blush. And the mortality, when you have the TMP grade 3, it is 2%, and when it is grade 0, it is 6.2%. So the tissue perfusion is extremely important. When you have TIMI 3 flow and TMP grade 3, actually the mortality is less than 1%. And that is correlated with better ST segment resolution and lesser fragmentation of the QRS. And the no reflow phenomenon, we know it's relatively common in primary angioplasty, and the risk factors are the advanced age, diabetes, late presentation, pre-procedural TIMI flow, and the advanced skill lip class at presentation. It is commoner in females compared to the males. And many studies are there, all small. 1548 STEMI patients, impaired reperfusion was associated with a threefold increase in the relative risk of mortality at 1 year follow-up. And similar results were observed at 5 years of follow-up. And we have studies with myocardial contrast echo and cardiac MRI, the prognostic impact of impaired reperfusion on survival and left ventricular remodeling. This is one small study which we did, 181 patients, primary angioplasty, looking at the no reflow and the ST resolution and the in-hospital mortality. People with no reflow had significantly less ST resolution and higher mortality compared to the group who had normal flow. This is another article, no reflow after primary angioplasty, a predictor of short-term outcome in STEMI patients. Look at the mortality, 14.58% with no reflow. With the normal flow, it is 4.46%. Similarly, the short-term complications, 33% versus 15.53%. So this capillary microvascular dysfunction contributing to the no reflow has significant prognostic value. And that is there right from the beginning, the in-hospital phase, and it persists for several years. We have data up to 5 years. The no reflow versus the normal flow. The curves continue to remain diverged. Predictive factors and impact of no reflow after PPCI in patients with acute myocardial infarction, there again you find the same thing. Myocardial perfusion grade 3, the survival is much better compared to grade 2 and grade 1 and 0. Unfortunately, the grade 2 behaves like grade 0 and 1 and not like grade 3. So it's very important that you achieve grade 3 myocardial perfusion grade. And the effect on the left ventricular ejection fraction, very striking. In people who have normal flow, the recovery at 6 months is very good. Whereas people with normal flow, you find the recovery is good. When there is no reflow, the recovery is very slow. Persistent no reflow is a thing which leads to persistent left ventricular dysfunction. The probability of survival, 1 year survival, normal flow, no reflow, and the point is it is evident right from the beginning, during the in-hospital phase, right from the day 1, the difference is very clearly evident. So let me conclude my talk. Microvascular dysfunction has an important role in many cardiovascular diseases. Microvascular dysfunction and coronary slow flow can be associated with acute coronary syndrome. Slow flow phenomenon is mainly related to microvascular dysfunction and is associated with adverse, immediate, and long-term cardiovascular outcome. Higher in-hospital mortality, reduced left ventricular ejection fraction, and electrical instability have been demonstrated in this group of people in multiple small studies. Microvascular dysfunction is one major factor contributing to stress cardiomyopathy because they have normal epicardial coronary vessels. Every effort should be made to protect the coronary microvasculature and avoid this risk. Thank you very much.